This section is entitled Antimicrobial Vignettes. We'll be doing 3 case studies that may involve situations you might see on the USMLE, and we will also be going over some memorization-based type of questions at the end. In this section, we'll be going over some antimicrobial cases and vignettes to test your knowledge about antimicrobials. For case number 1, we have a 25-year-old male who presented to the hospital with spiking fevers, malaise, left-sided chest pain, and cough. For the history of present illness, his symptoms started approximately 2 weeks ago, and they have worsened despite a full course of IV antibiotics. He does report a prior history of intravenous drug abuse. On examination, his temperature is 39.2, which is febrile. He's tachycardic and tachypnic. What organisms would be in your differential diagnosis for causing this illness? And what about his history of prior treatment with antibiotics without effect would make you more concerned in this patient? Some labs were drawn, and the CBC showed predominantly neutrophilic leukocytosis. His blood cultures are negative, but they've only been there for 1 day. Sputum cultures, however, have grown methicillin-resistant Staph aureus, also known as MRSA. What empiric treatment would you recommend for monotherapy for this patient, meaning you could only give 1 medication? And what about for combination therapy? Which medication would you give to this patient? So this patient has MRSA pneumonia. And medications that work against MRSA, like we talked about originally, are vancomycin, linezolid, Sinusid, also known as quinupristin and dalfapristin. These can all be used as monotherapy. For combination therapy, we can use an aminoglycoside plus one of these other medications. For this patient, how did the MRSA become encased in the lung? Most likely through the bloodstream. And therefore, it's very important in this patient to evaluate him for endocarditis, because MRSA is very commonly known to infect cardiac valves and may need a longer course of treatment. Again, MRSA is a big problem in intravenous drug abusers because it's transmitted through the bloodstream. It's also seen in hospitalized patients and patients that live in chronic care facilities. There are recent cases of high school athletes presenting with skin abscesses that contain MRSA. There is more methicillin-resistant Staph aureus present in the outpatient setting than there is actually in the inpatient setting. And the MRSA that's present in the outpatient setting is worse and more resistant than the inpatient MRSA strains. Other infections that can show antibiotic resistance, like we talked about, are VRE, Klebsiella, Enterobacter, E. coli, and Pseudomonas. That's why it's very important to culture these organisms to see which antibiotics they're resistant to. For case number 2, we have a 23-year-old marathon runner who's visiting his sports medicine doctor complaining of unsightly, embarrassing growth of his breasts as well as undue fatigue after training. Has a history of present illness. 3 months prior to presentation, he was put on daily oral therapy for severe refractory tinea corporis infection. However, he is unable to remember the medication that he was started on. Some questions. What was the medication he was likely put on for his tinea corporis or fungal infection? And what are the common adverse effects of this therapy? On physical exam, for this male, you see gynecomastia or enlargement of the breasts. You see tinea corporis covering the intertriginous regions. Intertriginous areas are areas where skin contacts skin. So this can include the groin, the breast, the armpit. Also, the infection for this patient involved the buttocks and scrotum. How can you explain this patient's gynecomastia? And what would you be concerned about if this patient were a renal transplant patient? So most likely this patient received ketoconazole or one of the azole medications for his tinea corporis infection. The most important thing to do is to discontinue this medication and try a different antifungal such as terbinafine, which does not inhibit the cytochrome P450 system. Remember, ketoconazole is a strong inhibitor of cytochrome P450. If a patient were a renal transplant patient and taking cyclosporine for the kidney transplant, and they started taking ketoconazole, the levels of cyclosporine would increase because cytochrome P450 is also responsible for breaking down cyclosporine. The other side effects of ketoconazole, as you know, include gynecomastia, fevers and chills, and impotence. For antimicrobial case number 3, we have an asymptomatic HIV-positive 29-year-old male who is visiting his ID specialist for a routine checkup. After determining his CD4 count is 410, the physician is at that point going to start antiviral therapy. 2 months after going to the doctor, he returns to the doctor's office feeling very tired. He's had 2 upper respiratory tract infections since his last clinic visit, and the day before presentation, he started bleeding from his gums. On physical exam, you can see slight tachycardia, and you can also see marked pallor, disseminated petechiae on his arms and legs. What are the possible causes of this patient's symptoms? Which medications which might have been started by this infectious disease doctor would have most likely have caused these symptoms? And which studies would you order, and what would you expect to show? The labs that were drawn for this patient showed a complete blood count with decreased platelets, decreased white cells, and decreased hemoglobin and red cell count. So we call this a pancytopenia. The treatment for this would be to discontinue AZT, which was most likely causing this bone marrow depletion, and switch to another anti-HIV drug. Some other questions that we'll ask at this point to make sure you understand, because these are very important concepts and most likely will be tested on the boards. What are the common tuberculosis medications? That includes rifampin, INH, pyrazinamide, ethambutol, and streptomycin, which is used as an alternative medication. And the mnemonic is RIPES. What are some common one-dose treatments for Neisseria gonorrhea? Those medications are listed here. The most commonly given are ceftriaxone and the other third-generation cephalosporins. What is the one-dose treatment for Haemophilus ducreyi? This is the organism that causes chancroid. Because it is of the Haemophilus species, it is very susceptible to azithromycin, and we can also use third-degree cephalosporins. What is the one-dose treatment for candidiasis? The most commonly given medication is fluconazole. Other medications will work for candidiasis as well, however, this is the most commonly given one. For trichomoniasis, the most common medication is metronidazole. And for Gardnerella vaginalis, the treatment is also metronidazole. This is the end of the antimicrobial vignettes section. Our next section will involve neuropharmacology.